And there is no Tuesday without your healthcare partners, brought to you by GRMC, where patients are partners. And to the studio, as I said, we're welcoming Dr. Michael Agustin. He's a pulmonologist and critical care physician. Welcome to the program, and thank you for coming in. Good morning.
Good morning, Patty. Good morning to all the listeners.
It's very nice to meet you. Dr. Michael Agustin has been on Guam for 2 years now.
For about a year.
For a year. Started with GRMC last September.
Exactly,
okay.
ma'am.
Yeah. And it's nice to have you here. You received your education both in the Philippines and then you told me in Boston.
Exactly.
Okay.
So I graduated my medical degree in the Philippines.
Mm-hmm.
I went to Brown University in Rhode Island for my residency for internal medicine. Then I went ahead for further training in pulmonary and also ICU medicine in Boston.
Wow. Well, you've come to the right place, especially for as a pulmonologist. You probably have seen your share of patients with lung problems on Guam.
Exactly. And
Is it typical for an island culture, or is asthma just a growing disease that affects us globally?
Yeah. Well, again, respiratory disease by all comers is one of the what we would say like common diseases like across the board. And the good thing about it is that again I'm surprised like in Guam really a lot of not only like respiratory disease but also respiratory hyperreactive airways disease, but also smoking related type of disease. So when we went to Guam, I think the first thing in our one of the things that we are trying to get into is actually have a good demographics really of what we have here in Guam. Again, GRMC is a hospital we only is the only one that has this. We call it the pulmonary function test. And again, anyone who has a cough, anyone who has a cold, anyone who has respiratory problems, it's so easy to tag them with asthma or things like that, all right? But there's really a criteria on how to actually diagnose a patient with either asthma or COPD or any other respiratory-related disease. And that's what we're trying to do here, is actually get into the bottom, diagnose them correctly, and get a sense what's the real demographics of our patients here in the island, and how does it differ back in the States or any other Asian countries.
Yeah. The knowledge of asthma itself has grown so much.
Exactly.
I remember back in the day, I don't know how old you are, but I do remember back in the day, you used to be able to get an over-the-counter medicine. What was, and they since outlawed it. Since you can no longer sell it. Remember that?
Exactly, albuterol.
But what was it? It was a brand name. I can't remember that you could buy right there.
I think Ventolin would be one of those brands.
Yeah, but what was the name of it? Anybody remember? It was a puffer. Gosh, it sticks in my head. Anyways, it's a big bulky puffer.
Exactly.
And then they took it away. They took it off the shelf because there were too many people who were misusing it.
Exactly.
Yeah, and so this is the point where I wanted to get in the conversation, because as much as their knowledge there has been about these lung diseases, there are people who feel like they know a lot about it. And so they self-medicate or they borrow other people's medication.
Exactly.
Right? Somebody once explained to me the greatest danger, particularly in children, is that they're treated one time for a respiratory ailment of some sort. And once they start to look and feel better and stop coughing or wheezing, the parent doesn't think there's anything wrong, when in fact that could be a lifelong situation that's not treated.
Yeah, and then again, well, one of the peculiar things about respiratory disease, again, asthma or everything, cough, should I say, would be a universal symptoms for everyone, and everyone would have different, again, cough should not be taken as a universal diagnosis for everyone. Like I have a cough, I have asthma, I have cough, I have COPD, I have cough, I have this. Again, there's a lot into the cough that we actually, us as a pulmonologist, would try to digest.
So you can tell the difference in the cough and what the nature of the problem is?
It's more of trying to see what's the real cause of the cough. All right. Again, one of the things is that this is one of the most frustrating symptoms of a patient, and sometimes it lasts long. And again, people tend to over-medicate themselves. People try to shop for medical specialty when they're having cough, because they're trying to actually try to have a fast treatment for this, but we always have to explain to our patients, like, trying to deal with your cough is really trying to deal what's the bottom line for this disease.
Yeah. So you could get relief from like albuterol and Ventolin, those kind of medications.
But we have to caution our patients, like if you don't have asthma, if you don't have hyperactive airway, using this for more than what's the recommended dose is sometimes not good, or sometimes even fatal for some of our patients.
So is it possible that the use of some of these more common medicines that are prescribed, if you even have something like bronchitis,
exactly,
could the prolonged use, if you don't address the real situation?
Exactly.
Oh, that's kind of scary, because these drugs are on the market. And in some places, for example, in the Philippines, it is easy to get these medications over the counter.
Exactly. So again,
wow.
part of the pulmonary evaluation that we have all our patients who come to our clinic is actually to have a pulmonary function test and try to give them a sense of what's your lung function at baseline, what's your lung function after we treat you, which phenotype do you actually go into? Are you more like an asthma type of phenotype, or you're like more of COPD if you have the risk for COPD and you have if you have been smoking, or you have this like infectious, prolonged infection, subtle infection type of respiratory disease.
And can you, by the way, thank you to my friend Brett, it was Primatene Mist. I don't know if you wrote, well, you're probably too young. He looks too young to be to know that, but that was an over-the-counter sort of, you could buy that with Tylenol. It was amazing, and then they finally took it off the market. Can we start from the beginning here? Is it possible to develop some of these diseases? Well, COPD, is that generally a disease that is caused by smoking?
Yeah, almost 90% would be related to smoking. It's a chronic obstructive pulmonary disease, and one of the major risk factors for this is people who have smoked. Again, studies have shown, especially here in Asia, again, there would be a slight difference between female who develop COPD because they are the one exposed to like cooking using like fire or wood fire or things like that. So again, studies have shown that there might be some changes, or there might be some peculiarities, especially here in Asia.
Note to self: stop barbecuing. Give it to somebody else. No.
And also the occupational related type of disease can cause this.
So that's COPD. What are the other? Asthma, for example.
Asthma, as I've been always telling my patients, like this is a disease of the young, right? So seldom do we see a patient who would be like at their fifth or sixth decade of life, and he would say, "Okay, I was just diagnosed with asthma." Okay,
that's interesting because how is it that adults find out that they have asthma? They've always had it and it was untreated, or
it's more of like, again, that's the mimickers, right? Like you may have like a hyperactive airway, you may have colds that triggers coughing, you may have GERD or reflux. That's what we tell our patients, and that's actually, it's an acid from your stomach that goes to your throat, and it actually destroys or makes your throat inflamed, and it mimics an asthma type of symptoms. And again, you may have like an exposure to your work that may trigger hyperactive airway, and it mimics like an asthma. Or you have a subtle infection, be it from a mold, be it from a cousin of TB. We call it the non-tuberculous mycobacterium, which mimics like a chronic cough, and it comes and it goes. And people, when they try to see you, hey, it seems like you have asthma because that's how it looks like when I was young, and that's how and you take some over-the-counter or steroids, and you actually get better. So those are the mimickers.
Would allergies fall under that as well?
Exactly.
Okay, so especially like at a season like this, when there's like, I know that sometimes it gets a little difficult when you get the live Christmas tree in your house, and all of a sudden you've introduced something that into the environment that wasn't there before.
And again, 60% of the patients with cough or chronic cough that I see in my clinic would be, it's all related to an upper airway disease, like post-nasal drip. And the way to treat that is actually not treating, trying to identify the allergen or trying to treat the nose.
Well, this is helpful information for people who are still in that sort of gray area. Because, like I said, you kind of self-diagnose, and which is a very dangerous place to be. So trying to find the balance between somebody who's just having maybe an allergic reaction to something, may have COPD, may have had asthma for a very long time, but generally starts as a child, and then the treatment of it. Okay. So go ahead.
Yeah, and that's how we actually profile our patients in our clinic, is actually try to actually go into what's their work, what's their exposure, did they travel anywhere, are there some family members with similar symptoms, what's the exposure, like have you been exposed to molds or things like that. Then you go to diagnostic, like CT scan, pulmonary function test. We test your sputum, we test your blood, we test your allergy level in your blood. And that's how we could give you a good profile and say, hey, this is what's causing your cough. It may start with just a cough going to my clinic, but we have a full profile of a patient, or we try to get a full profile of the patient and try to at least give them the answer on what's causing their cough or respiratory symptoms.
If you are currently taking medications, or you've had a prolonged, you've got a diagnosis that, for example, you've got asthma.
Exactly.
They have different medicines that are out there, an array of medicines. Is it possible, is it possible that you can become immune over long time use?
Exactly. Again, asthma can the treatment for asthma, because this is something reversible, right? This is something that you have symptoms and we could reverse it. Again, if your symptoms tend to persist, we try to look into other things. Is this infection related, or is there any other phenotype? Is it allergic related type of asthma? So asthma, if you try to digest it, it goes to a different level, especially when it goes to difficult to treat asthma. That's a whole lot of array of diagnosis, whole lot array
difficult to treat asthma.
Exactly. When we have a patient that comes with us, and again, like I told you, asthma in the pulmonary field is one of those that doesn't have a clear-cut definition. I personally try to follow my patients for 6 months to a year before I actually drop the diagnosis, like, hey, you have asthma. But up until I don't see them and try to see how they actually perform over a year, I tell them this could be hyperactive airway. This could just be allergic reaction.
Well, most people will go to their regular doctor if they're sick, urgent care, or they'll go someplace to emergency room, or however they come upon their regular a regular doctor who will sometimes diagnose for them.
Exactly.
And so that patient thinks that they've walked away with a diagnosis. Are all doctors necessarily qualified to be able to make that diagnosis?
Well, again, hyperactive airway, I would say yes, but actually diagnosing, especially for adults with asthma, again for younger patients, like for younger patients, like pediatric patient, again, it's actually clear cut. Like if you have a hyperactive airway and all this stuff, you could actually diagnose them with asthma. But for for an older patient who never had history of asthma, I think we have to be cautious about diagnosing them with that, especially if they have smoked, especially if they have risk factors, especially even cancer alone can cause you chronic cough. And if you just try to limit yourself with just asthma and treat it, again, we may be missing important things. And that's why if you have cough that seems not to be it's been going on for quite some time, again, we actually suggest being seen by a pulmonologist, so at least we could actually diagnose it further.
And that'll have to actually be up to the patient to kind of be assertive that way, because if they go in with this information and you're diagnosed with asthma without any other further testing but whatever appears to be the symptoms, then you might be being misdiagnosed. So the patient should ask the doctor.
Exactly.
Could you recommend I go if you really think I have it?
And then again, we promote open communication between us and me and some of the primary cares. I have open communication with them, and they could call me at any time and say, like, I have this patient that they think they have asthma, I think they have hyperactive airway. I tried to do the first few remedies, but it seems like it's not working.
And that has to be somebody who's really paying attention to that patient, and that means that you have to have a regular doctor that you see all the time, primary doctor that you see all the time, who knows you and knows your chart.
Exactly.
And sometimes that doesn't always happen.
And then again, it's also the threshold of the primary care. Like, give them limits. Like, again, if your cough doesn't go away in 2 weeks or in a month or 2 months, again, you have to come back. Again, that's the key there, right? Like, again, having a close follow-up with patients that it doesn't seem like it fits the puzzle for just a bronchitis or just a common cold. Again, an early follow-up with them would actually give us a better clue that this patient may need more diagnostic more than just regular treatment.
Most people say when they've even got something like bronchitis, which is treatable, right? That they say, I would rather have any other disease than one that makes it very difficult to breathe. Do you hear that too?
Yeah. Yeah.
I mean, of all of the ailments, the one where you can't breathe is the most difficult.
And that's why I went into pulmonary, because again, this is one system that it has the highest impact factor for a patient. Again, cardiovascular, neuro, if you actually had been, it could debilitate you. But the unique thing about pulmonary is that you could see some changes if you treat them well.
Okay.
The impact of respiratory illness is high, especially in work and family. But again, if you treat them, you could also see a good improvement.
COPD, these are diseases, like you said, are primarily caused by exposure to chemicals and smoke and that sort of thing. Is that reversible if you were a smoker?
Well, it's more of the part of our, it's again, before people would actually, if you have COPD, it's non-treatable, right? Again, I have to emphasize that this is actually a disease of an older people, like they would be on their 6th or 7th or 8th decade of life when they show it, because again, that's the time that your lungs age out and the effect of the smoking would actually kick in. Again, we have some patients who come into us by their 40s or 50s who have COPD, and that's a unique case. But again, most of my patients, I would say 80% would be in the elderly population. Again, it's actually trying to decrease the fast decline of the pulmonary function. That's our job, because once you fall into that very steep decline, your symptoms would actually get worse and you end up in oxygen.
So there is, I mean, but as you get older, let's say, as you get older and your lungs do start to weaken, but you're not a smoker, you've actually had a pretty good, healthy life, as they do. Is there anything that you can do to prevent or not?
It's more of the degree of steep decline that we see on people who have smoked that actually produces more symptoms more than those that haven't smoked.
Yeah. Well, I tell you, excuse me, Paul, could you pop me up over here? I wanted you to hear. Somebody sent this to me. This is Bob Gibson, who was a former baseball star in a 1982 commercial on Primatene Mist. This might even have some shock value for you, Doc. Here we go.
Gibson. My fastball isn't so fast anymore, but this is Primatene Mist, the fastest type relief known for occasional bronchoasthma attacks. Restores free breathing as fast as 15 seconds. And Primatene tablets help prevent attacks for hours.
In the lungs, Primatene opens clogged tubes, relaxes bronchial spasms, restores free breathing.
Get fast relief.
Yeah, it is.
Also, Primatene tablets contain the asthma relievers doctors prescribe most. Primatene.
Isn't that amazing that something like that could be on the market, knowing what we know now about the dangers of that? It is possible to die of asthma, even if you are being treated or if it's managed?
It is. We call it status asthmaticus. So even if you're on treatment, if you catch this infection and if the degree of inflammation is so severe, you go to respiratory arrest. And we've seen patients like that.
I've heard about that happening, but this is something that there's nothing you can do, basically, unless you are seeking... you're under treatment, but some of them are unseen.
Exactly.
Yeah, some are unseen. You could talk to me about the fact that you are also a critical care physician. We didn't even go there. Your plate is full.
Exactly. So, but again, in addition to asthma and all this stuff, again, asthma, COPD actually are entering within this year or the coming years would be entering into this realm of new medication. Again, asthma alone, they're trying to look into immunotherapy for these patients, and we go into even to the genetic part of asthma, and that's how we particularly treat them. And hopefully we could have those. Again, there are 2 or 3 medications right now in the States that just got approved within the past 2 years. And
what's the latest medicines that are out there currently?
Exactly. Right now it's more of an inhaler, inhaled steroids. That's one. Albuterol, which has been there for a long period of time. Now we've looked into the genetics of asthma and tried to see like components. We call it the IL-5 and all this stuff. And there are a lot of like new medication.
Well, like Advair or like Singulair. Are
those are part of the inhaled corticosteroids.
Oh, I see.
But if there's like a difficult, and that's where the difficult to treat asthma. That's where the time that we would actually go into a deeper studies on try to look into their phlegm, try to look into their blood, and then try to see if there's the new immunotherapy available in the States that are FDA approved. Like 2 of them are FDA approved. And
what are they? What are the latest?
One is the mepolizumab, which is both are IL-5 inhibitor.
Okay.
And although these are
Is that a puffer? Is that a
no,
medication?
These are IV medications.
Oh, IV medication.
Omalizumab had been there for quite some time already. So these are the things that, again, that's why we wanted to profile our patients that we see and try to separate those who are difficult to treat that we see in our clinic almost every month, and try to separate them and try to study more on this patient.
So you're, in addition to treating this clinically, you're also trying to incorporate this research in order to separate
exactly
what we're talking about.
I think that's a key that we wanted to have here in Guam. I think we are in a place that we actually have a good way to profile patients, because we're on the island. Like all follow-ups will be on this.
It's a manageable population.
Exactly.
Yeah.
And again, you could actually have a real-time score on how they follow up and how they are. And again, if we try to profile our patients and try to separate them into demographics, again, you would be having a better way of treating them. Like that's how. So all the patients that we had, that we've seen in the clinic, that's what we're doing, is try to see, hey, which patient would this belong? Would they belong to those patients that are difficult to treat asthma or difficult to treat respiratory disease because they have infection or chronic infection, versus those that are more an allergic type? And try to see, because if you have this profile of patients, then you could actually go into these new medications and try to say, hey, I have a population of patients that have this.
But would that only work if you're within the GRMC system?
I think we'll have to hopefully
figure out a way
exactly.
to broaden the research. But you'd have to engage other doctors that do the same thing.
Exactly.
And y'all have to be on the same page.
Exactly.
I mean, and then there's a limited number of you, right? And our petri dish is only so big.
I know. I think so. Right now we are, I think, 3 or 4.
Okay.
3 or 4
Is that adequate for the numbers of breathing difficulties and breathing?
I would say it would be like 1 in every. Again, studies would tell you like 1 in every 70,000 or 100,000. But again, the degree, like it also depends on how much they would be presenting to your clinic for symptoms.
Wow. But, Guam, talk to me about the environmental factors, the external factors that we have here. We don't have season changes, but we certainly have wind changes and climate changes, right?
And again, my wife is also, I'm working with her on this pulmonary disease that are caused by chronic infection. And I would be very honest, like Guam had been like the most that we've seen so far for a year.
Wow.
In our program alone, we've been following 35 patients for a year just for this chronic patients with chronic indolent infection presenting with chronic cough or chronic respiratory disease. Again, that we call it bronchiectasis, right? And again, that's something like huge for an island alone.
The 35, the number is big?
I think it's bigger. Like these are the only 35 that we actually put it in our system, and those.
That's just 35 that you know of.
Exactly.
In other words,
exactly. 35 that actually had received chronic antibiotics, 35 that we follow closely, 35 that we. And again, enrollment is still ongoing.
Yeah.
Because again, these patients would end up again. What we wanted to do for these 35 or more patients is actually not to end up in the emergency room over and over again. Not to end up being hospitalized over and over again. So we have to have a close look at them, because if they have symptoms, they could actually call the clinic quickly and not end up in the hospital, because that would actually lessen the cost for the patient and also the hospital or the entire healthcare system in Guam as well.
Wow. What would you, just for the sake of children and for the adult audience that might be listening, what would be some of the red flags that you would be able to tell in a child that might have a problem?
Well, I'm mostly an adult pulmonologist, but all comers, again, cough that is that's been persistent. We call it a subacute cough. If it's been persisting for more than 2 weeks or even for more than a month, that's already a red flag. If it accompanies hemoptysis, you spit up blood, or you spit up like a blood streak in your phlegm. Weight loss, night sweats. Again, what I'm pointing out is, again, one of the things that we worry both in adults and in the children is tuberculosis. And again, we've seen a lot of cases of tuberculosis in the island. That's one thing that my wife and I had been an advocate of, is try to diagnose and try to limit
the spread.
Yeah,
Yeah. And
spread.
here we've had quite a few cases.
Exactly. And again, I want their presentation is actually also unique. Some of the cases that we have, they've been thought that they may have cancer. They've thought that they may have other diseases, but again, surprisingly, they do have tuberculosis.
Wow. Dr. Agustin, it's very nice, a very interesting conversation. Thank you so much. I learned a lot, and you verified a lot of information that I heard about before.
Exactly.
But it is all about the education. You can find your regular clinic is at GRMC.
Exactly. So if I'm not doing my regular intensive care duties, which I do,
which you do all the time.
Exactly. Every other week, my clinic is located, and both me and my Dr. Gonzalez, who is another pulmonologist, our clinic is located at the first floor of GRMC. And again, any primary care physician listening, again, we're open communication is the best key for this. Again, you could always call us and try to, so we could settle some of the things, and we could always accommodate your patients in our clinic.
I mean, that's the first line of defense, really, and then having a patient that understands these differences and can talk to their doctors and be a little more assertive or aggressive in their care by asking the doctor, should I go and see a specialist for something like this?
And again, we don't fault our patients who are vigilant with their health.
Yeah, why not? Hey, go ahead, make a lot of noise. Thank you so much for your time. I really appreciate it. I look forward to meeting your wife. You guys are partners, so I guess she'll be coming in soon as well.
Exactly.
All right. We'll be looking forward to her probably next week. In the meantime, Merry Christmas, Doc. Thank you for coming. Your Healthcare Partners brought to you by GRMC, where patients are partners.